right, good evening, everyone. Welcome to the February installment of the ACFAS Student Research Lecture Series on Meta-Analyses and Systematic Reviews. We're excited to have you all here to join us. Tonight, we have two speakers, Dr. Jessica Knight and Dr. Rachel Albright, talking to you about systematic reviews and meta-analyses. Dr. Albright is a graduate of Dr. William M. Schull College of Podiatric Medicine. She completed her residency at Advocate Illinois Masonic Medical Center in Chicago, Illinois. In addition, she completed her fellowship at the Dartmouth Institute for Health Policy and Clinical Practice. Dr. Knight is also a Schull graduate who completed her reconstructive foot and ankle surgical residency at Metro West Medical Center in Boston, Massachusetts. In addition, she completed her fellowship at Weill Foot and Ankle Institute in Arlington Heights, Illinois, and currently participates in mission works in Honduras for the treatment of children with congenital birth abnormalities. Thank you so much to our speakers. We are incredibly thankful to hear you speak tonight. Should anyone have any questions throughout the presentation, please write them in the Q&A portion at the bottom of the screen, and questions will be answered at the end of each speaker. Without further ado, please welcome Dr. Albright.
Thanks so much for inviting me to be here with you guys. So I'm representing the ACFAS Research Committee. I'm also a section editor for JFAS and an associate editor for JATMA. And I'm going to talk to you guys about systematic reviews and meta-analyses. So just a little disclosure, we only have about 25 minutes together, so it's not going to be a comprehensive review. It's just kind of meant to be a Cliff Notes version of how to perform these reviews well. If you have questions at the end, or if you want to do a deeper dive, I do have some information at the end for some really good resources for you guys to look into to help you out. So I think it's really important to understand the power that certain study designs can have. And I think that understanding the power of a systematic review is best done with an example. So let's examine a problem. So let's say that we are physicians, which we all are, and the problem we're looking at is sudden sensory neuro hearing loss is an idiopathic condition, and the current treatment is not clear. Okay, so that's kind of the issue we have. We're looking through the literature, seeing what it shows, and we come across this study. So it's a double-blind clinical study, and it's looking at the efficacy of steroids for the treatment of this sudden hearing loss. And we look at the results here, and it says that steroids had a statistically significant effect on the recovery of hearing in patients with moderate hearing loss. So as a healthcare provider, what are you going to conclude from this? Well, if I don't know what the best treatment is, and I'm seeing this study, seems like a reasonable study design, it's showing that it's effective, I'm going to start prescribing systemic steroids for this problem, right? Seems reasonable. But, you know, fast forward a couple years to 2007, and this meta-analysis comes out, okay? So this meta-analysis is looking at randomized control trials that looked at treatment for hearing loss. And if you go down to the conclusions here, it says, despite traditional practice in North America of treating hearing loss with systemic steroids, the meta-analysis found no evidence of benefit of steroids over placebo. So this is a really great example of the power of a systematic review and meta-analysis. So one thing that a meta-analysis can do is it pools data together, so it increases our sample size, and it can allow us to find associations that we didn't know exist. And it can also allow us to disprove associations that we thought existed. And this was a problem, you know, in the healthcare system. This really was treated with steroids for a long time until something like this came out. That first study was from the 80s. So in 2007, this came out and actually disproved that treatment option that people were using for a long time. So what exactly is a systematic review? It's just a synthesis of similar data. So you're trying to pool data together to come up with some kind of summary, right? It's really best for topics where the data is currently unclear. So that's if there are differing opinions between surgeons. One person thinks treatment A is better, one person thinks treatment B is better, or if there's contradictory data. So this study says that this treatment is great, and then this other study says that it's not so great. Those are really good conditions for when a systematic review can be really helpful. It's definitely best for focused topics, okay? It's not really meant to be looking at topics that are going to have a ton of variables, a ton of outcomes. It's just not the best for that. You should have a pretty focused topic. And there's a couple of things that you definitely want to include in your systematic review. So these are 7 things that I've listed here. You definitely want to identify a specific research question, okay? You should have a well-defined systematic approach. it should be a comprehensive search of the literature. So you're trying to find all the studies that are addressing the question that you're looking at. You have to assess the quality of the methods of the studies that you're including. You should show individual study characteristics in a table or a figure. You want to synthesize your findings, make a conclusion, and be transparent in your methodology, okay? So a systematic review is not just a literature review. There's specific criteria that's required for it to be considered systematic. So what's a meta-analysis? A meta-analysis is basically the formal statistic that you'll find alongside a systematic review. So if a systematic review contains some kind of formal statistic, it's probably a meta-analysis. If you're doing a meta-analysis, you should absolutely assess heterogeneity. You should absolutely assess publication bias, typically in the form of a funnel plot. And you're going to probably want to do a sensitivity analysis or subgroup analysis. Now, why do you want to do this? Well, first of all, it's fun, okay? This is the most fun part of a meta-analysis. If you're going to do it, do the fun part. And subgroup analysis are particularly interesting because a subgroup analysis can investigate different groups to see how they're affected by the treatment. So you can assess only women, only men, and just pull that data out and see how only this group of people is affected by a treatment. So that can be particularly interesting. So why do we do meta-analyses? The larger sample size increases the power, like we talked about. We can identify associations we didn't know there were. We can find oddities in studies that weren't apparent before, and we can investigate if subgroups are affected differently by a treatment. So this is your typical systematic review protocol. Everybody should have a protocol. It doesn't have to be exactly like this, but it should be something. So the background section. Every research project has a background section, but for a systematic review specifically, remember we talked about one of the conditions where a systematic review is really helpful is if there's conflicting data. So in your background section, you should really talk about why this review is necessary. If there is a topic where most surgeons are all doing the same thing for it, probably not the best topic for systematic review, right? We really want to look at differing data because when we pool the data together, we want to see which one comes out on top. So if it's the same one coming out on top all the time, it's probably not the best one for a systematic review. Your research question should clearly state your 4 PICO elements. So we'll talk about that in a little bit. You need to have clear inclusion and exclusion criteria. And then of course your search strategy, which is one of the most important parts, which is going to describe your search terms as well as your preliminary results. So just some things to avoid. So these are some things that I've kind of found in reviewing systematic reviews and meta-analyses. These are the 3 biggest things that I found that are kind of barriers to publication, I would say. So if the review lacks a systematic approach, okay, typically you can tell because the search will not be a combination of keywords and mesh terms. You've got to have a combination of both, not one, both. It needs to be comprehensive, okay? So you're really trying to find all the data that is on this subject. You're not trying to leave anything out. It should really be a comprehensive search. You really want to avoid limits to your search. Now, if you're searching a condition that is really vast and there's just so much data on it, then you can put limits on your search. Typically, that's not going to be present in foot and ankle research. In the big realm of research, foot and ankle literature is kind of scarce. So I would really caution, anyone here for our purposes to put limits on their search. Secondly, the second biggest issue I see is there's a lack of focus in the research question. There's too many variables included. The outcomes are unclear. There's too many interventions. It kind of just becomes a big mess, to be honest. And it's really difficult to come up with a summation of the results and then come up with a clear, concise conclusion. And if you're having trouble doing that, it's probably because your research question is not focused. And the last thing I find is not sticking to your inclusion criteria. Not much to say here, but if you have inclusion criteria and you don't stick to it, that's not research, not even research. So definitely stick to your inclusion criteria. So here's your PICO research question. So this is an easy way to come up with a research question. It really helps you focus. Specifically for systematic reviews, your population, you want to be specific. Consider the disease status. Are you only looking at people that have had 6 months of treatment? Consider the age, the gender. Intervention, this doesn't necessarily have to be a therapy or a medication or a surgery. It could be something that a group was exposed to. So if you're not looking at a therapeutic study design, if it's more of an observational study design, it might not include an intervention, and that's okay. That can still count for your eye. A comparison group, really helpful if you're doing a meta-analysis, not required, but really helpful. So I would highly recommend it. And then your outcome, really important to have a clear definition of the outcome. There are things called, so there's two types of outcomes that I like to think of. There's hard outcomes and soft outcomes. So a hard outcome is something that's not subjective. So that would be something like mortality. No subjectivity to that. Everyone can agree that this person is with us or they're not with us, right? But if you look at something more like functional status after bunion surgery, a little bit more subjective, right? And that's when you need to have a very clear definition of your outcome. What patient-reported outcome measure are you using? What score do they have to have on that measure in order to say that they've achieved that outcome? So these are all the things you should be thinking of and be very specific on that definition. Gold standards, if there are gold standards currently in the literature, you're obligated to use them, because the point of these reviews is to try to add important data to the literature. And if you're not using the gold standard, you're kind of like not, I don't want to say you're not adding important data, but it's just a little bit iffy. I mean, I don't know what the excuse is, I suppose, for not using a gold standard if there is one. So that means you have to kind of score through the data and know what the gold standard would be. So here's an example of a research question. What are the postoperative outcomes of adults undergoing bunion surgery? Some of you might think this is a bad question. Some might think it's a good question. I think there's some issues with it. So these are the issues I think are present here. So the intervention's not clear. What type of bunion surgery are we doing? Is it only Lapidus? Is it a scarf versus a Lapidus? What are we doing? The outcome is also unclear. What specific outcome are you looking for? Is it functional status? Is it pain? Is it getting into shoe gear? What is it? There's no clear comparison group in this research question. You could be looking at two different types of bunion surgery together. Again, if you lack a comparison group, you can still do a meta-analysis, but it's honestly difficult. You're lower in your level of evidence right there, right out of the gate, by not having a comparison group. It's already lower. You're not going to achieve more than like a level 3 evidence study if you're not going to include studies that have a comparison group. So consider that. And the follow-up is unclear. So what time period are we trying to obtain the outcome? 6 months postoperatively, 12 months, et cetera. So a couple of things are unclear with this research question. This is probably a little bit more of a clear research question. So what are the promised physical function scores of adults undergoing Lapidus versus Austin bunionectomy for IM angles less than 18 degrees at 1 year postoperatively? This is one sentence, and there is a lot of information here. So we're using our PICO, right, to make this question. So here's our population here, very specific, adults with an IM angle of less than 18. We're looking at Lapidus versus Austin. We're using PROMIS for our outcome, and we have a specific time period. So sometimes people added T to the end of PICO, and I added that here. So our specific time period is 1 year. So inclusion and exclusion criteria. This should be done before the search is undertaken, all right? Not after, not during, before. So the research question needs to be done before, and the inclusion and exclusion criteria needs to be done before. So some things that you're thinking about for this kind of criteria is, what time period of studies am I going to include? Am I going to include studies from the 80s? Do I only want to include studies from the last 10 years because I know that the research really boomed in the last 10 years on a topic? You know, you have to make that decision ahead of time. What study designs do you want to include? What type of study design is going to be the best to answer your question? The population, are you only looking at studies that have a control group or some kind of comparison group? Think about the length of follow-up. Really, in your inclusion and exclusion criteria, your aim is that you're aiming to obtain the best data that is most needed and influential for the readership. So that's what you should be thinking of as far as what kind of study am I going to include to answer this research question. So some study designs can affect your inclusion and exclusion criteria. So a retrospective study, for example, the highest risk of bias is mostly in the data collection phase because the data has already been collected, it's already in existence. So you have no say in how that data was collected. So you have to be really careful with that. Look through the studies, see how they obtained the outcome, how they collected the data, and see if that's something you're okay with and if that meets your criteria for a high quality study. You also want to consider when in the disease state you're going to accept enrollment in the study. So this is pretty big for a retrospective study in that sense. Prospective studies. Now, these have more control over the data collection phase because it's being collected kind of as the study is going. But you want to consider the loss to follow-up, right? You can have a randomized control trial that is double-blind, placebo, whatever kind of adjective you want to add to that to make it sound really exciting. But if you have a high loss to follow-up, it is not level 1 evidence. So just because you have an RCT does not make it level 1. So it's important to understand that and consider the loss to follow-up. You could be significantly reducing the level of evidence of your study if you're including RCTs, but you're not looking at loss to follow-up. So consider that kind of thing for a prospective study. So let's say we've gotten past all that. So we've identified a problem, we have a well-developed research question, we have our inclusion and exclusion criteria, and now we're ready for the search. So how do we do that? So performing the search, definitely one of the most important parts of the review, okay? This can make or break you. If the search is not comprehensive and you submit an article like for publication and I do your search and I find 3 other studies that should have been included, it's getting rejected completely. It's not getting sent back for a review, it's rejected because it has to be comprehensive. That's the whole point of a systematic review. So that's number 1. Second thing is for the search, you need to have a combination of keywords and mesh terms. We're going to go over that. The search needs to be well documented, not only for the method section of your study, but also for your Prisma diagram. And you're going to thank yourself later for this. Every single study that you exclude needs to be accounted for in that diagram. And if you have 20 studies that you just forgot about, it's a huge pain to go back and try to remember, oh, why did these studies get excluded? So keep track of that, have a well-documented search. You have to search multiple databases, not one. One database is not comprehensive, is it? So you have to search multiple databases. My recommendation would be 3, but you can kind of make your decision on if it's comprehensive or not, sort of. Consider if you want to include non-published literature. So abstracts of conferences, you can look through the abstracts from ACFAS and see if any of those abstracts meet your criteria and have the data that you need. You can look at the references of the included articles. You can ask an expert. Experts know what data is out there. They also know if there's a study undergoing right now that might have data available for you. So you're really trying to literally look in all the nooks and crannies in order to find this data. Elicit the help of a librarian for your search. This is what they do. They're quite good at it. And they can help you figure out what keywords and mesh terms to use. You also want other people to look at your search. You should not be creating the search by yourself. There should be you should probably have at least 3 people look at your search criteria before you actually undertake it, because you're trying to find all of the keywords and mesh terms that could possibly be used in the literature to describe your research question. So a search turntable is a really good way to organize your thoughts. So I'm going to kind of show you how to use this. So let's say my research question is, does PIPJ fusion following hammer toe surgery occur more consistently with a K-wire or an implant? So the easy way to do this is to come up with themes, large overarching themes for your research question. Now, the easiest way to do this, in my opinion, is just to split it up by your PICO. So your population is people with hammer toes. That's a theme. Your intervention and your comparison is K-wire versus implant. So I made that one theme. And then arthrodesis is your outcome. That's your third theme. Now, why did I not make this 4 themes? Why didn't I make my intervention one theme and my comparison group another theme? The reason is because, like I mentioned before, foot and ankle literature is kind of scarce. So the more themes you have, the more narrow your search is. If you have less themes, you're casting a wider net, and our net needs to be big enough to capture all the literature. So if we make it too narrow, we might miss something. So I typically go with 3 themes for foot and ankle literature, maybe even 2 themes, if you're just not getting a wide enough net. So these are my themes based on my PICO question. And then these are the mesh terms and the keywords I used. And these are real mesh terms and keywords. So the mesh terms are obtained from Medline, aka PubMed. And you're going to see that these mesh terms are not exactly the way that you would probably say it. So for example, a K-wire, so that's one of the themes. And the mesh term for K-wire is bone wire. It's not actually K-wire, it's not Kirshner wire, it's bone wire. So you actually have to look these things up and make sure that you're using the correct term in the way that it's indexed on that database, okay? And then your keywords are not going to be index terms. It's going to be the way that you as the author might describe this, but you're also trying to think of the way that all the other authors might describe it. That's why you want to get multiple people to look at this. Maybe someone else is going to come up with a term that you didn't think of. So you want this to be as comprehensive as possible. And then you're going to use a combination of ands and ors in order to create your search term. So the ors are across a subject, and the ands are kind of down when you're connecting 2 subjects together. So for example, it would be hammer toe syndrome, or toe, or claw toe, or mallet-toe, etc. for that subject. And bone wire, so we're going to the next subject, or K-wire, we're staying on the same subject, so it's going to be or, etc., etc. And arthrodesis, that's your 3rd theme, or fusion, etc. So that's how you build your search term. It takes kind of a long time. It needs to be redefined over and over and over. If you're searching and you only get 100 searches, you need to start over. That's not good. You want definitely a couple hundred, maybe 500 or more. If you get 1,000, excellent, I like it. But if you're working with less than 500, you might want to consider to redo your search. So when you're reviewing the articles, there's typically going to be 3 reviews done. So let's say you have all of your articles, you did your comprehensive search. You want these reviews to be blinded if possible, okay? So you don't want the other authors being influenced by each other and talking too much about this. Your first review is the easiest. That's your title and abstract review. You are eliminating articles that are clearly off topic, very quick. If your subject matter is on hammer toes, if somebody is presenting on gout, nix it right away. Someone's presenting on flat foot, gone. We don't need it. Totally, clearly off topic, right? So that's your quick review. The second review is a closer look at the abstract. So that's when you're going to start to read the abstract a little bit closer, and you're looking for some inclusion criteria. A lot of these abstracts are only 250 words. They're not comprehensive. If that abstract does not have all the information you need, you do not get rid of it unless it's clear it does not meet the criteria, which it might not be clear just by a 250-word summary, right? If it's not clear, you keep it until the next review, okay? So that's your second review. The third review is your full text review. That is your last chance to vet these articles for inclusion in the data analysis. All of your inclusion criteria needs to be met in order for studies in the full text review to make it on to the analysis phase. So how will you come to a consensus? 3 reviewers minimum, okay? So 2 reviewers should review blinded, go through review 1, 2, 3, and then if they disagree on anything, a 3rd reviewer is kind of like your tiebreaker. So just some tips for organizing the data. Like I said, 3 reviewers is the minimum, not a solo mission. You cannot do this with 1 person. You can't really do it with 2 people. 3 is the minimum. Find some friends and do it, because 1 or 2, not enough. Consider using a referencing software program. Seriously, you're going to really appreciate it. You're going to go through thousands of references and you want to keep them organized. Keep track of your duplicates. If you're looking through multiple databases, you're going to get duplicate studies, but you have to keep track of that, because the Prism of Closed diagram is going to ask, how many duplicates did you have? And if you didn't keep track and you just deleted them, like that's gonna suck. Another thing, have a master file of all the references you pulled in your most comprehensive search and never modify it. You will thank yourself for doing this, because as time goes on, you're going to come across studies and you're going to be like, did I include that? Did that get pulled in the initial review? Did the search pull that? Go back to that master file and check it. I can't even tell you how many times I've done that. So definitely keep a master file. So we're gonna have to skip this part. Sorry, I know analyzing data is kind of exciting, but we're gonna have to skip it for the sake of time. But really quick, risk of bias down here at the bottom is kind of where I'm talking. You have to assess the quality of the studies included. This is not an assessment of level of evidence. That is not it. You are assessing the risk of bias. So there are risk of bias tools that you utilize to do this, and what you're trying to do is figure out if biases present in the study might have over or underestimated your results, okay? This is a list of risk of bias tools that are commonly used. You might want to snap a photo of this. These are different study designs and then different risk of bias tools that are typically used. Now, some of these overlap, right? So a cohort study is an observational study, right? So the Moose guidelines is used for observational research. Strobe also used for it, but you can also use the Newcastle Ottawa scale. How are you going to know which one to use? Use the one that makes the most sense to you, that's easiest for you to use. Or if you know the journal you want to publish in, they might have criteria on which one they want you to use. So keep that in mind. And we're just going to skip to the end here. As promised, here is some information for anyone who's interested in going into a deeper dive. The Cochrane Handbook, really great guide, has a step-by-step guide on how to conduct a systematic review. It's like 100 pages long, but it's worth the read. Prisma, one of the biggest guidelines for quality reporting for systematic reviews. There's a checklist. Go through that checklist. Make sure that you check off all those things. They also give you a template for a flow diagram. Beautiful. Use it. Flow diagrams are typically required for publication. So for the sake of time, so that we can listen to Dr. Knight, feel free to email me if you have any questions, but thanks for your time, guys.
With that, thank you so much, Dr. Albright and Dr. Knight, for this wonderful presentation, and thank you to all who joined us for the program today. And like I said, if you have any further questions, whether you want to have them answered today or in the future, please feel free to contact either Dr. Knight, Dr. Albright, or myself. Have a great night.